Chief Executive of Salford Royal Hospitals Trust, but also who has gone on to take on the Pennine Acute Trust and turn that around. Next up, we've got Kevin McGee, Chief Executive of East Lancashire Hospitals Trust, and also George Eliot Trust before that, which went through a series of special measures with the CQC and has successfully come out of that process under Kevin's leadership. And then next on we have Diane Sarkar, the Chief Nursing Officer at Basildon and Thurrock University Hospitals Trust, which had its own problems with mortality and special measures, and through her leadership and those at the Trust turned that around. And finally, Sue Smith from the Morecambe Foundation Trust Hospital, where of course there was the well-known maternity scandal and now transformed maternity unit. So, David, if I could ask you to just kick us off, first of all, with your brief 5 minutes of your experiences with Pennine Acute.
Sure. Thank you very much, and I'm pleased that so many people did return, although I notice you're all closer to the exit door than you are here. A number of you may know that I've now entered my 18th year at Salford, and thoroughly enjoyed the role that I've got there. But 2 years ago, our neighbouring organisation, Pennine Acute, were experiencing significant difficulties, and we were asked if we would support them and offer some leadership. This was an organisation which I think has had a troubled past and history, and without much due diligence, we stepped over and went in to offer support. A number of you may know that in my 18 years at Salford, the last 9 years, we've been involved in a quality improvement program. Our ambition to be one of the safest organisations in the country is what we have focused on and continue to do so. So we had an understanding, and I guess maybe a naive belief, that we could take our learning from one organisation to codify that and introduce it into another, and see whether we would be able to get improvement. Well, I remember in my first few weeks of going around and meeting staff, these are 4 hospitals. It's the largest non-teaching trust in the country. And I went to stand in front of groups of staff, and at the end, after I'd said my piece, I got the usual response, which was, we've heard it from guys like you before who've stood in front of us and said all the things that you're going to do. Why should we believe we're going to hear something or experience something different from you? And that sort of knocks the wind out of you, I have to say. And I had to begin right at the very beginning. I wasn't known in that organisation, and neither were the team who were coming in and the senior leadership teams that we brought into each of the hospitals. So at the very heart of what we've practiced is to make sure that leadership is present, is visible, and is authentic. You will know that you can lose it in an instant by saying you're going to do something and then behaving or acting in a very different way. So we had to prove ourselves right from the very beginning that we meant this, that we would be there to support people, that we would be introducing change, that we knew it was going to be difficult. We would be introducing some of the methodology that we had tried and tested in Salford. But we would be clear as well with holding the mirror up and reflecting either what people were saying or the results that they were experiencing. One of the important things, I think, is that you have to understand the variation that exists in an organisation. I hear too often when I visit other organisations where people talk about an aggregate level of performance or outcome. And you will know that if you've got 20, 30, 40 or 80 wards, they'll all be different. But at the heart of what we do is try and measure what's happening in each one of those caregiving areas, and to provide it with an assessment and to see that variation, so we know where some of our better wards are, and we know where some of the difficulties are, where extra support is needed. We also strongly believe and practiced within Pennine this idea, which was very different to the one that I experienced myself, my own style 10 years or so ago, which was previously to bring people into my office to brainstorm a problem, come up with a solution and push it into the organization. And I now reflect just how arrogant I must have seemed to people to know the solutions that were going to work in their areas. We operate very differently in Salford and have introduced this now into Pennine as well, where we want to get staff who know the problems that they're experiencing, the impediments to change, to come up with the ideas themselves, to work with others, to test those ideas, to measure whether a change in a process results in improvement. Most of you in this room will know all of this and be practitioners in it. But we do this in a very disciplined way. And I think going back to the conversation I had with staff early on about how we would involve them, they would be very much part of the improvements that we were putting in place. Has been what they continue to experience, which is they come up with the ideas that we test and measure, and they agree whether they have effected a change or not, and then we spread that across the whole of the hospitals or community services. Lots of other things that we've got in place. Time's not going to allow me to talk about them, about really listening to the views of our patients, and perhaps most importantly, those who know them better than we do. They're close members of their family. We're also very interested in how we support our staff to give of their very best. I'm a particular fan in two aspects. One is to give people feedback as much in the moment as we can. I'm not very good at doing this myself, but it's hugely important that we allow people the opportunity to be given feedback and to reflect on the contribution that they've made. We're also introducing a new approach to coaching as well, of getting staff to really think about not just what they do, but how they do it, about their behaviours and the values that we espouse as an organisation. So I will hold there because I think that I'm slightly over time. So there we go.
It's fine. Kevin, talk us through your experiences with George Eliot and East Lancashire.
Okay, thank you, Sean. We all know what to do. I don't think there's anything that we can tell you that people won't already know. There's nothing clever about what we're going to say. But in spite of it not being clever, in spite of us knowing what to do, in many instances we still don't do it. And it's because the how is really difficult. Getting into an organisation, working with individuals, working with clinical teams, working with organisations, it's really getting into the DNA of an organisation. So there's something about having standard approaches and being able to use them, but making it specific to the organisational. It's contextual, and that's really the difficult thing, the how in the context of the organisation. My last two posts have been in two organisations that have had issues, safety issues. So there was a George Eliot. It was one of the original Keogh trusts that went into special measures because of high mortality rates, and then East Lancashire Hospitals Trust. In terms of the George Eliot, I was really proud of that organisation in terms of the way it acted and reacted to going into special measures. And it was actually the best thing that ever happened to that organisation, because for the first time ever, we were able to put external support around that organisation, but also as a chief executive, it gave me levers to pull internally within the organisation in terms of how I could work with clinical teams, with clinicians to actually talk about processes and behaviours and change things. So there is something about never wasting a good crisis, and that happened. East Lancashire was slightly different. By the time I got there, it had come out of special measures, and we'd taken it from a CQC to a CQC rating of good. Still masses of work to do. But what I passionately believe in both of those organisations, every staff and every staff member that I work with wanted to do the right thing. There was not one staff I came across did not want to do an improvement, did not want to improve and deliver better patient safety outcomes. What we had to do, what I had to do, was to create the climate in which people had the confidence to actually do and to push the work. Because what I've found in organisations that are in difficulty, it's almost like the lifeblood's been sucked out of those organisations. The fun has been sucked out of those organisations. People have their heads down, literally and metaphorically have their heads down. And it's about raising that, putting some fun back into the organisation and allowing people to have the confidence to actually take some of those risks. The other point I would make is that I've sat in so many meetings over the last few years in both those organisations, in different organisations. People say, we want to change, we need to transform, we need to have better outcomes. But the debates really don't go that much further because, again, it's the how. So one of the things I really passionately believe in now, and something I'm trying to introduce within our organisation in East Lancashire, is a process around service improvement to really be able to systematise, standardise and industrialise how we improve services. We're lucky we're one of the organisations that are now working with NHSI through the Lean programme. It could be any approach, but it's really important because you need something. As a chief exec, I need a lever to be able to pull within the organisation that gets people behind what we're trying to do and where we're trying to take the organisation. And having a standardised approach, I think, is key. I would characterise some of the work that we've done previously within East Lancashire as being something of a scattergun approach. We've had lots of different collaboratives, different improvement approaches, all been under the banner of what we call safe, personal, effective care. It's our catch line. Everything's been under that. And it's worked to an extent. And we probably had to go through that learning curve to have that level of different approaches. But we're now at a point, I think, in terms of the maturity of the organisation where we can take it to a different place and we can really standardise the way we do our improvements and the way we look at the outcomes for the future. And so on my agenda for taking the organisation forward, I'm not unashamed to say our objective is to make Pennine Lancashire the best health and social care system in the country, bar none, underpinned by the best levels of staff satisfaction. Because I passionately believe, again, everything starts and finishes with our staff. If we get them in the right place, they can then deliver the care, the outputs that are required for our communities and our population. And there's three things now that I'm really focusing on and trying to get the organisation focused on. Firstly, it is about that leadership of that overall approach to service improvement and quality. That has to come from the board. It has to come from me. I have to lead it. I have to go through the training. I had to even lead some of the work that we're doing in terms of the improvement collaboratives themselves. The second thing is an approach to quality and safety that's based on leadership, based on compassionate leadership. It's not words, it's a real something we're trying to embed within the organisation that will really help with staff engagement, staff morale. And then the third point is how do I take an organisation that's been built up through the years, been standalone organisations, and take it into a system where we work much more as a system, as part of an integrated health and social care system that links personal health care right the way through to tertiary health care, that has a link between it through systems approach to improvement and has that linked to compassionate leadership. So an awful lot to do. I wouldn't pretend to say that we've got the answers to everything, but we're really clear about the messages we're trying to give out and how we're trying to actually do this improvement journey.
Thank you, Kevin. Diane.
Thank you. Thank you all. So I'm going to talk a bit more about the personal side of things. And I was reflecting on Ted's comment about the CQC not there to batter you. So in the process of Basildon becoming under the spotlight of the CQC to us coming out of special measures, we had 14 CQC inspections, 2 KEO reviews, 2 NMC reviews, plus the GMC, health and safety, everybody and anybody coming in to review the organisation with weekly CCG, reviews, audits, inspections. So I think it's fair to say the staff were pretty battered. They felt very battered. And I always use the analogy, we always had to develop an action plan for whichever regulator it was that came in. And I remember at one of the KEO reviews being criticised for having too many action plans, and then we were asked to develop another action plan for the KEO review. So there was a key lesson there around actually being really robust and standing up and doing what was right for the organisation at that time. So what I just wanted to do was just talk you through some of the things really that we found really important at the grassroots level of the organisation. One of them was around the culture, and we've heard that a lot this afternoon. But what was the culture? What was the culture in our organisation? And we did a lot of work around assessing that culture from board to ward, and there were lots of things that needed changing. It wasn't necessarily open, honest and transparent. There was a very big feeling of being defensive. The board at the time were accused by CQC, by, as it was, their monitor, of being a defensive board. There was an absolute focus on finances, less than quality. That was the situation back in 2010. So there were some lessons there in terms of actually what could we do different. There was also a bit around, and again, we've heard it around listening to staff, but we actually thought, how do we do that? How do we really change that culture and listen to staff? So we introduced a daily stepping up session. So at 8:30 every morning in an open public place, in the staff, in the main restaurant of the organisation, we have a 10, 15-minute standing up meeting where anybody in the trust is welcome to come, patients, relatives as well, where we do a kind of situation of the nation. We share the patient safety, quality issues. We talk about the staffing levels, are they safe? And it's a meeting where we can solutionise things at that point in time. So that was introduced, and staff actually really felt very valued and listened to. And if an issue couldn't be solutionised at that meeting, it was brought back the next day, and there was very much an action tracker where we could follow through on things. Another thing we introduced was Swartz Rounds. Very, very powerful, and again, we held those monthly, and they still continue now, where again, staff can share their feelings, their views about an incident, and have very much that reflective practice. So there wasn't just the bit around staff, there was also the bit around our patients and relatives. And certainly in Basildon, there's the daily RAG, which actually for us was quite difficult. So there was lots of engagement and listening to the media, engaging with the stakeholders, and doing lots of sessions with patients and visitors at the time. We had open surgeries for staff as well, where we did listen. There was also the executive visibility, and I think previously the executive team weren't visible. People didn't know their names, people didn't know who they were. So we actually instigated a very robust executive visibility, but also the board visibility out on the wards, listening to staff again. I think there were some things also that where staff had felt very battered and they'd felt very criticised by the regulators and indeed patients, there was something about articulating with staff what was good, what could they be proud of, and actually for them to be able to articulate what their unique contribution had been that day to patient care. What had they done to make their services safe? So that was a real challenge, and actually it's still a challenge trying to get staff to articulate what's good and what is outstanding has been a key challenge. I think some of the other things that we did was introduce quite a robust governance framework with very strong monitoring arrangements around it. I alluded to at the beginning around the action plan scenario, but there was performance management, there was holding people to account, and that had to be developed and created and embedded in the organisation. I think some of the other things that we did was really around that staff feedback, feeding back to staff what's happening, listening to what they were saying, and on a regular basis, going to their team meetings. So there was lots of things that fed into that cultural side where staff were listened to. They came to us, they listened to us. We had an open email system where staff could send in their comments and their concerns. And actually, it wasn't also just about being open and honest with our staff, it was about being open and honest with the regulators. So proactively telling them what we were doing, what the issues and concerns were, but more importantly, what we were doing about those issues and concerns. And that was a real fundamental change for us, certainly in our discussions with the CQC, was being open, honest with our risks and our challenges. And I think, you know, one key message that I certainly would like to give you to take away is what can you demonstrate to the regulators that is good? And that's one challenge that we are still doing with our staff is what are you proud of and what do you do that's outstanding?
And last but certainly not least, Sue.
Thank you. So, hello. I guess from our perspective, the perspective of Morecambe Bay, we have a legacy that will never be forgotten. Can you just show me has anybody heard about us over this last 2 days? Put your hand up if you've heard Morecambe Bay mentioned. Now put them down if you've heard that in a very positive way. Oh, well, some people have, that surprises me, but that's really great. Why will our legacy never be forgotten? Because babies and mums died in our care. We had a closed culture, a culture where families and staff were not listened to, but even worse than that, were often ignored. Doctors and nurses worked in isolation. There were poor behaviours, poor governance, appalling staff levels and skill mix, and very poor role modelling at every level. Worst of all, there was no recognition that this wasn't acceptable. It's a classic example of what we call normalising the abnormal. You sort of get used to the poor standards and then you accept them as normal. When you read reports about Morecambe Bay or any of the other catastrophic failings in the NHS, you're going to notice a theme. So it doesn't matter which one, but Morecambe Bay had the same themes. A culture where patient safety and staff well-being isn't considered above the ambitions of the organisation to meet financial or regulatory targets. That certainly happened at Morecambe Bay. And when you read all of the other catastrophic reports, very, very similar theme. A culture where learning isn't shared, where people don't talk about things. I've heard really awful stories from my own senior team members where they'd raised a problem and they'd been told by their board member, don't raise a problem. If you don't like working here, you know what you can do. Hopefully that doesn't happen anymore. But does it? Do you know for sure? Do you know for sure? Changing culture is a really, really tough task for leaders because you have to start with building trust with patients and families and staff who are suspicious and disempowered. And it is really tough going into an organisation where you're dealing with very, very angry and rightly angry families because you've done harm, your organisation's done harm. There are 3 areas, 3 take-home messages that I want to concentrate on. And I can't go into any of them in great detail because we haven't enough time, but the first one is listen and learn. We are now open and honest, and we're open and honest before we know if we've even done something wrong. We will tell the patient if something has happened as we expected it to happen, and we will let them know that we'll investigate it, and we will. And sometimes we find that actually we did everything that we could possibly have done and nothing could have been changed, and we will tell them. Other times we'll find that something led to that error, and we will also tell them. But more importantly, we learn together, and we learn with our families. When you look at Kirkup and the Kirkup families, and I've heard James speak, and every time he speaks, it makes me want to cry because he is absolutely correct. You know, his story is heartbreaking, and it should never, ever happen again. Some of the other families that we've worked with are the biggest advocates, and also James Wood, he sends people to us to come and learn about how we've changed. And the biggest thing that we've done is we've listened and learned from the families, and it's changed us. It's changed the board, and it's changed our frontline staff, but not just in maternity. And I think the thing about Kirkup for me is the learning should not just be applied to maternity, it should be applied to every service. And that's what we've done at Morecambe Bay. our job as board leaders is to listen, to learn, and to continuously adapt and adopt. I'll give you an example of the way that we have changed, and it's nothing to do with maternity. It's a learning disability patient who needed a life-saving operation. Our organisation worked with other organisations and the family, and we actually, and I think it's the first time it's been done nationally, we went into a patient's home, intubated them in their home, brought them into hospital for their life-saving operation, took them home in the ambulance, we extubated and we recovered them in their home. Because without doing that, they would not have had their operation. We are a different organisation and a different culture. The second lesson for me is to empower staff. And I think, I've heard my colleagues say the same thing. But if you empower staff, they will come up with the changes in practice and culture much more quickly than you can do in any other way. And the example I want to give you there, and I've heard people talking about deteriorating patient today and yesterday. But one of the things that we did is very, very quickly, by doctors and nurses learning together, we realised that we weren't capturing deteriorating patients. We do that incredibly well today, incredibly well. And tomorrow morning, we will be hearing about all the incidents from last week. We've reduced our cardiac arrests by 70% over 4 years. 70%. Our HSMR, our hospital standardised mortality ratio is 77. That's really, really low. And that's because we're listening, learning, and empowering staff. And my third takeaway message is be brave. We can't continue to work in an NHS that doesn't change as fast as it needs to. We have to be the people who make it change. We have to listen to the front line and enable them to make that change. And the example that I'm going to give you there is a couple of years ago, I had nurses telling me that they were really worried. 1 in 4 of our patients has a mental health need. But we're not well equipped in the general hospital to deal with that. I had vacancies, and I had nurses telling me that they were really scared of dealing with very, very challenging of very challenging patients. So we also had learning disability nurses and mental health nurses without jobs. We put 2 and 2 together, and we took on mental health and learning disability nurses. Everybody told us we couldn't do it because general hospitals can't do it. But guess what? It works really, really well. And our patients are better, our staff are happier, the skills are transferable. We've put skill packages in to wrap around them. Be brave, start to think outside the box. We can't run the NHS like we always have. And our legacy, hopefully, moving forward will be that more of those hands will stay up to say we've heard good things.
Well, we're going to... I was going to say everybody deserves a round of applause for the work that you've done, but one of the reasons we're here is to talk about the how you've done it and to give these messages to the audience. Please get on our live Q&A and submit your questions, but I just wanted to ask each of you, and pick and choose who wants to respond, but you've all talked about staff and empowering staff, communication, etc., but we all know that there will be, in challenged organisations, those individuals who've perhaps been there a little too long, or they have a certain worldview and they are resistant to change. Perhaps they are the problem. In each of your cases, are there examples where you've just had to deal with a member of staff that crossed a line? And if so, I mean, that's very difficult, isn't it? How do you do that whilst at the same time you're not trying to show the rest of the staff that they're on the block as well? If you understand what I mean. I don't know who.
Shall I?
Diane, yeah?
Yeah, so I think, I've got 2 examples. One, I think, with those difficult staff members, I think there's one issue around performance management, and certainly at Basildon there had previously been a lack of performance management, so there's a bit around making sure that you're holding the right people to account for the right things that they're doing or not doing, as the case may be. And then I think the way is sometimes to get that person on board and get them to lead a piece of work to make that change and then hold those individuals to account. And certainly we had a member of staff that was very anti doing something, and actually we've got those on board to lead that piece of work, and actually they became a changed person and a changed leader, and it really enhanced some of their skills and their negativity, so it did change the whole culture of that department as well. So it was actually getting them on board.
And Sue, I know at Morecambe you had to do that as well, didn't you? You had to say goodbye to a few staff, which...
We did, and I have to say, when I arrived in Morecambe Bay on the 2nd of December 2013, there were 22 registered midwives who'd been referred to the Nursing Midwifery Council, and it was really difficult to find a backstory. It was really, really difficult to try and work out what had happened. It's the most challenging thing that I've ever done in my entire life. It's really, really important where there are failures that we actually make note of those failures and that we can show what we have done to try and support people through it, and where we can't, that we've done the right thing. There was none of that, so you have to start again. What became very, very clear was staff themselves know where the problems are. They know which colleagues worry them. And what really, really upsets them and unsettles them is seeing people get away with things, seeing people not being dealt with in a robust way, in an appropriate way, when they want to keep getting better. And I think that's one thing that we've learned, is actually people want to know. And the one thing that we still don't get right all of the time is when somebody does raise a concern about somebody's practice, is we're still not very good at feeding back to say we've addressed this, because we're always so... we're always trying to maintain confidentiality, but we've got to find that balance between ensuring that people know that something's been done where it's appropriate without giving away too much detail. I think that is still a problem in the NHS.
I think one of my experiences was to recognise that when staff hadn't been listened to, when nobody was really paying them much attention, that I shouldn't have been surprised that they'd get on and find ways of doing things. And often those ways were not the ways that they should have done, or we would have supported. We were just talking before we came on stage about a number of examples. I mean, there was a surgeon who thought it was appropriate to write "Do not resuscitate" in a felt tip pen on the lady's leg, and there were countless things that we had come across where staff had not thought that. Well, they might have thought that was inappropriate, but didn't speak out because nobody was there to listen to them. So we had a board and senior leadership that was disconnected from the staff, and it does take time. I think some behaviours are unacceptable no matter what. Others, people have to really know that they will be valued and listened to, and trust has to be built between senior leadership and those who are working in wards and departments. And once you've done that and they're clear about the behaviours that you expect, then I think you can recalibrate and determine what is appropriate and what isn't. There are now over the last 2 years fabulous examples of ward managers, departmental managers who've really come into their own, doing some great things in the 4 hospitals in Pennine Acute. But there are also a smaller number of people who, no matter what, still thought that they could behave in the way that they chose, and we've had to act. And there has been...
There's a balance there, isn't there? If you go too far against staff, then everybody feels they might be targeted by the trust leadership.
Yeah, but I think the point that was made, that people do know. They know what reasonable behaviour is and what isn't. And I think if you are clear about values and giving people feedback on their behaviour, then it doesn't take too long to make the adjustment. And I said right at the beginning of my talk about standing in front of groups of staff and them saying, we've heard it all before. It is very different now. I mean, I know we've got colleagues in the room from Bury, Rochdale, Oldham and North Manchester, but it is palpably different now talking to staff there about the extent to which they feel involved and are active in our improvement activities. It's it is very good. Early days, but very good.
There's a question on Slido from Helen that actually sort of follows on my point around how do you go about breaking up damaging cliques within teams and moving staff around to better skills, a move that is deeply unpopular amongst staff. I mean, Kevin, but...
Yeah. I once had to work with the chairman who had a saying, there's no such thing as a difficult conversation. only necessary conversations. And I think you have to just be really consistent in terms of the behaviours and the standards that you accept within your organisation. And if you see behaviours that fall below what's acceptable, you have to be able to deal with it, because if you don't, it then becomes really infectious throughout the organisation. As colleagues have pointed out, other staff know that, and other staff then question what you do. So provider organisations, NHS organisations, there are cultures within cultures within cultures. So there'll be an A&E culture, there will be a theatre culture, etc. And you've got to really understand each individual part of the organisation. You can't just take a blanket and standardised approach. However, there are certain behaviours that are unacceptable wherever you are. And I think as a leadership team, and particularly from the executive team, you have to give that consistency of approach and make sure that people are really clear that there are lines that cannot be passed, and if they do pass, action will be taken.
There's a question from an anonymous person, which is the top-rated question at the moment, which is about, as a patient who's suffered harm, and you know, I don't want to be listened to or pitied. I want to be, I want to need to deserve to have a big say in how health professionals tackle safety. When and how will you let me in? And of course, Sue, I want you to respond to this, because I know that at Morecambe Bay you did exactly that, didn't you, with the victims? And I know that it was, I remember talking to the chief executive, Jackie, who said it was possibly the most difficult thing she's ever done, is bringing together the midwife who harmed James's son Joshua and James himself.
It was, and actually, should be really interesting, because she would also share, I'm sure, her story. But it is important, and I think, you know, we shouldn't tick the box of listening to somebody. Actually, we need to bring them in, and we need to really hear what they're saying. We have involved the families who we harmed, the Kirkup families, in designing and developing, or redesigning and redeveloping all parts of our maternity services from the new build that we've just had. They came in and they reviewed our policies with us, are learning with us, absolutely every element. They sit on interview panels with us. Sounds strange, 2 of the Kirkup families actually now work in our organisation as healthcare support workers. So they wouldn't do that if they didn't believe that we were changing. The trick now is, in our surgical services, we're doing really well in involving patients, and only last week, because we still get it wrong, only last week we had a patient who was very concerned about the appointment system in breast services. And so we brought that patient and a couple of others. It quickly came as a theme. So we brought those patients together with us to help us work through what works for them. And I think, you know, what we have learned is actually it's much easier. It's actually quicker to put the effort in and listen to people. Let's stop being advocates. I think traditionally we've been advocates for patients. Actually, let's not be advocates for patients. Let the patients be advocates for themselves and their families, and let us be the people who listen and do the right things and make it happen. And I think that's the difference between, you know, the NHS that we all know, the traditional NHS, where everything's done around clinicians, to changing the way that we work. And
is that common for the other 3 of you? Have you all taken that leap of bringing in bereaved families to help improve services? And that must be really challenging.
It's as Sue said, it's probably one of the most challenging things that you can do. And just to build on what Sue said, I think we've got to move away from where I think we were a while ago, where we looked at patient stories and then we advocated on behalf of patient stories, to actually bring in the patient and their families to the centre of the improvements that we want to make. So, you know, we have a number of methods and approaches to doing that. But I think that there's something slightly uncomfortable for me where we advocate on behalf of patients, we use patient stories, but it's always in the abstract. We have to have patients right at the centre of what we do, working with the clinical teams, instructing the clinical teams, because there's something really, really powerful about when the patients and their families are sitting in the same room discussing their issues with the clinical teams, and the changes that can come from that are incredibly powerful. And it's not just changes to the systems and the processes that we run, but actually changes in attitudes of behaviour of staff that work in the NHS. That's the most powerful change.
And I mean, I'm causing me to remember a young man who had a lifelong condition. So he was looked after at Alder Hay Hospital and then transferred to Salford. And he died in our care. and he died in our care because we didn't listen to the person who knew most about his condition, and that was his mother. So his mother had watched the signs of his deterioration occurring on a Friday and continued into the weekend. She spoke to nursing staff and spoke to the consultant in charge, and I mean, without going into the reasons here, she wasn't listened to. And had she had her voice been heard, then we have concluded that Mark would have lived. And so we had to have that conversation with her and the family. It was deeply distressing for her and the members of staff involved. But we learned a tremendous amount from that. We've a unit that's named after Mark Holland. But one of the things that we did do with the support of the family is we've introduced a phone number by the side of every bed where we encourage the patient or the family obviously to talk to their responsible nurse or doctor. But if they're not getting the answer to the question that they want, then they can dial that number and they're put through an independent switchboard to the most senior nurse on call, who will visit them within 4 hours. And if still they're dissatisfied with the answer, then they'll speak to an executive director who will respond to them that day. So it could be me or one of my colleagues. And that was as a direct consequence of involving Mark's mother and family in reviewing some of the things that went wrong in his care.
So there's a question here which I think is really interesting from Cicely Cunningham, who is asking basically, what can you do as senior NHS executives to engender change with your executive colleagues in other trusts where the culture is still one of not listening and instead blaming staff who speak up about safety? And it's fair to say we have a panel here of people who you guys embody perhaps the one end of the spectrum, and we know that not all managers are as good as you guys. And Cicely's point is quite good, I think, is we do have a problem there, don't we? What can we do to get other executives to adopt and change and then be able to embody that in their organisations?
So I think it's hugely important, and I think if you track these things, there was a few years ago there was more interest than I think there is now in being able to be supportive and to share information. A number of us were involved in the buddying schemes that were available, and I think that they did add something to the amount of knowledge that became available into the NHS. I think now people probably think, well, we're doing this and we've got the regulator and they're telling us how things could be different. The amount of learning between organisations, I think, has diminished. And I think that's not for the good. So these events are really important. You know, this particular congress, I think, is important in the calendar of the year to continue to share. I have a strong view, which I know that you know, Sean, that where best practice does exist, it is possible to codify it and seek to introduce it into other organisations. And I'm afraid we're still standoffish about that. You know, we're 235 sovereign organisations in a national health service, which is only national by the means by which we collect money and pay. It's not national by the way we provide services. It isn't standardised, and I think that there are different ways in which we could explore how we can take best practice from organisations that have tried and tested ideas and to make those available to others. So. Maybe in these years to come, there will be the opportunity to do this and experiment with it, and be supportive of introducing those the good things that work into other organisations. I can talk more about that, but I'm sure colleagues probably want to. Yeah.
So I mean, I think just echoing everything that's just been said, but I think we are and should be in the time of continuous improvement, and I think it's our responsibility as senior leaders to not duplicate work and not be afraid to ask for help and not to be afraid to share the things that have not gone so well as well. And I think, we're always very keen to share the good stuff, but actually we should also share the things where things have not particularly gone well so that we can learn lessons from, not so good areas. I think also we should be exploring opportunities to share and work with other stakeholders, other partners. So it's a system-wide thing. It isn't just about an acute provider, particularly in my instance. So it's that system-wide learning I think we should be exploring. And I certainly, Basildon was buddied up with another trust. And in fact, we came up to Salford and saw Salford's work as well. So continue that work and that sharing of lessons and that buddying, even if it's not within a trust, but an exec-to-exec buddying up, and making sure that we also explore all of the opportunities of mentoring and coaching, and making sure all of our teams have a mentor and or a coach as well.
Sue, you wanted to come in on...
Yeah, so when I first went to Morecambe Bay, actually before Morecambe Bay, when I was chief nurse at North Tees and Hartlepool, I followed your red bus. You had a bus full of people whose lives you'd saved, through all of your improvements at Salford. And when I went to Morecambe Bay, the first thing I did was ring Elaine and come through to Salford. And we adopted and adapted some of your really good practices. It wasn't all perfectly right for us in its form, but we adapted some of that. And we do the same for other people now, because my ambition was always to have a reputation like Salford had. I think we're getting there for those people who know beyond, the tragedy that we have caused. So we share very, very widely. And this month alone, I've got 3 different organisations coming to spend time with us to do the same thing. And I think, we have to do that. Unless we do that, unless we challenge each other, unless we help each other, we're never going to move forward. I think the other thing is, though, let's not just look at leadership from the top, because I think it's really, really important, and I invest a lot of time in, and our whole board does, in our frontline staff, whether they're porters or students. Students are incredibly important. They're our future leaders. They're the people that will be looking after us. So for me, make sure that we've got, that we're actually role modelling, that they know who we are, that they understand what behaviours we're looking for, and we will have a safe future in the NHS, but I think we've got to do it both ways.
Yeah, Kevin.
Can just add one point? I mean, I'm a great supporter of the buddying. I've been buddied in both of my previous organisations, and we're now helping in working alongside another organisation. And actually, I think the buddying works not really for at my level. It's more about the interaction between the operational and the clinical teams, and getting them to interact and share good practice. And I think the more that we can do that at that level, the better will be that sharing of practice, because I think it's really quite fundamental. We've grown up over the last 20 years in an era where organisations have been sovereign organisations, there's been competition, etc. We're now trying to move to something very different about integrated care. And if we're really going to move, and that really means something, that sharing of good practice between organisations has to be at the root. And I don't believe it's at our level. It can have something at our level, but it's absolutely at the clinical and operational team level.
And actually, I think the point you've just made, Kevin, echoes what Bill Kirkup spoke about this morning when he gave a keynote, which you could hear a pin drop in the room. Everybody was gripped by what he had to say. But one of his key points was, in all of the cases that he's been involved in, those units or those trusts became isolated. It was all to do with isolation. So if it's the chief executive sharing knowledge, but also the clinical teams as well, perhaps that's a powerful tool. Diane, you mentioned the plethora of inspections and regulatory interventions that you had, and there are some questions coming through that are very similar around resources, and is that linked to this, and also around the regulators. How do you drive improvement at a ward level, whilst at the same time having that tidal wave of external intervention?
I wish I had the answer. So I think there was a point where we really had to kick back almost and say, we will do and pull together the plan that we think is right, because back in 2012, it felt like all of the regulators weren't all talking to each other, and they were working in silos. That's how it felt to us as an organisation. So there was a bit about us taking absolute ownership about how we developed those plans and what was going in those plans. We equally at the time set up a PMO office so that things could be monitored, and that came into the governance arrangements. Now the organisation's in a very different place, so we talk to the ward staff, we talk to the ward teams, what are their top things on their risk registers, what are their key issues, and what do they need to support and development with. So it's much more of a bottom-up approach now across the organisation in terms of what needs to be done. Of course, there's still the things that come down from the board that need to be done, but it's the whole governance arrangements have changed in the organisation to make it much more robust. So it is a bottom-up, top-down approach to pulling together those action plans. I think the other thing that did really come out during the inspection regime, and it goes back to the bit around staff engagement, we did get to the point where complacency wasn't an option, that the organisation had been accused of being complacent, so that isn't an option. And the other thing in terms of action plans was very much around make sure that the action plan is very smart. It isn't putting sticky plasters on. We've got to do action plans that are sustainable moving forward. And that was really a key challenge. There were lots and lots and lots of action plans, but they were very short term. They were addressing a problem at that moment, whether it be that week, that month, but it wasn't a long-term sustainable thing. And the organisation has really very much changed to making sure that the action plans are robust and that they are sustainable in changing patient care moving forward.
Yeah, Kevin, you said the CQC was one of the best things that ever happened to your trust. Would you say the same thing about the interventions from NHS Improvement, NHS England and your commissioners?
So I saw some of the best behaviour and I saw some of the worst behaviour. When the George Eliot went into special measures, we were very lucky. We buddied with a very good trust, University Hospitals of Birmingham, and they came and they supported and they worked alongside us. But there was also a lot of predatory instincts from organisations as well, and caused a degree of instability and uncertainty within the organisation. So, I would hope that we are past that now, and the era, we are past that, and people would act in a different way. And I think the regulators have matured and moved in a different way. And are more supportive in terms of how they're working with us. And I'd take the example of what we're doing with NHS Improvement and the work around lean. But the one thing I'd say in terms of trying to put that stability in and trying to create that capacity is if you want organisations to change, you want individual parts of organisations to change, you have to bite the bullet. There has to be some capacity and capability to do so. So, one practical example, and we've by no means cracked this at all, what we're trying to do on each of the wards now is to have a very senior Band 7 supernumerary nursing lead. Supernumerary so that they can work on the culture, they can work on the rotas, they can work on the whole culture of what needs to happen on that ward to make it a high-performing ward. If you don't have that capacity, you don't have that capability, people are too fixated in doing the day job and doing what's necessary. So you have to be able to put capacity in. Unfortunately, it costs, and we know the issues around that. But I don't think there's any shortcut. You have to recognise that you've got to have the capacity to change.
I just want to quickly, on the issue of resources, Kevin was referring to then. Of course, there is the equation of quality improvement equals an efficiency improvement, but one of the things that we did when we first became a foundation trust all those years ago was set aside £1 million to establish our quality improvement directorate. We couldn't have done what we have now been able to show without making that initial investment. But the most important thing is that we're not going to be able to make our changes in a reliable, resilient way without workforce. And you can't dodge it. You have to have safe staffing levels in order to deliver the things that we're all capable of delivering. There are, across all of our organisations, too many gaps in rotas, too many of our staffing rotas filled with locum and agency staff rather than having the continuity that we should have. So whilst I welcome the resources that government are going to be putting into the NHS, it is not going to deliver us the workforce at the speed that we want. And that is, I think, a real concern for all of us who have an interest in assuring standards of service and wanting to make sure that we're operating safely. Yeah. We've got to have the workforce, and we've got to be able to have safe staffing levels.
We're running out of time, but I just wanted to ask each of you for a sort of final last point to our audience. There'll be people out here today who are thinking, I know there's a problem on X ward, or I know this unit or site has a cultural issue, and I don't know how to crack it. What would be each of yours, just as brief as you can in this scenario, what would be your advice to individuals who are trying to think how they move forward from there? If I could start with you, Sue, and we'll go down the sofa.
Be honest and raise it, and if nothing happens, raise it higher. And keep raising it. If necessary, go through whistleblowing. But if there's a real problem and you're worried about it, you have a duty to do something about it. We can't just allow people to, have worries that are potentially founded and might do harm.
Be robust in acknowledging what the issues and concerns are. Have a robust plan with robust monitoring arrangements to ensure that it's sustainable. Do not put sticky plasters on things.
Be brave and be prepared to put your best, most experienced, most skilled staff in the areas where you've got the biggest issues, and let them do their work.
Ditto, ditto, ditto. But I would say if you are in a position of leadership, wherever you may be, just really think about the relationship that you want to develop with the staff that you have a responsibility for, because that matters, I think, more than anything else. Building that trust with people so you can actually get at the discretionary effort that you won't otherwise be able to command. That has to be freely given, and that comes from having strong relationships through staff that are trusting their leaders. So all of you in leadership positions, really think about how you can engender that spirit of teamwork and the building of trust.
Ladies and gentlemen, what an excellent panel.